Hi, I'm Andrew Spencer. I'm a Professor of Hematology at Alfred Hospital-Monash University in Melbourne, Australia. I'm here at the ASH meeting in San Francisco presenting the results of LEOPARD. This is a phase 2 study of maintenance lenalidomide and prednisolone post-autologous stem cell transplantation for myeloma, incorporating minimal residual disease monitoring. So this study really had multiple purposes in our institution and in some other centres around Melbourne, in that we were interested in comparing different methods of monitoring minimal residual disease following transplantation, because it's still unclear which modality is going to have the most utility in clinical practice. So we have gathered material in a cohort of 60 patients post-autograft to enable us to measure free light, heavy light. We've done multi-parameter flow cytometry, and we're in the process of getting next generation sequencing done. So we've got 4 modalities looking at residual disease in those patients that have attained complete remission. We've also initiated some studies looking at proteomics. So this is looking at molecules such as cereblon and Icaros at baseline to see if they impact on the kinetics of attainment of maximal response in these patients, or whether in fact they can predict for early progression. And finally, we've also got karyotypic and FISH data to see if we can predict patients who may not benefit greatly from this sort of intervention after a transplant. So this study was undertaken at 6 centres in Melbourne, and it was for patients who'd undergone a first high-dose chemotherapy conditioned autologous stem cell transplant. And really the eligibility criteria were therefore quite inclusive, and we rapidly accrued the target population of 60 patients. And we've now got quite long follow-up on these patients to help us interpret better the study endpoints that we've indicated, particularly the impact of potential proteomic or karyotypic prognostic factors. The intervention was started at approximately 6 weeks post-autograft and comprised lenalidomide on a continuous basis, initially at 10 milligrams and escalating to 15 milligrams, combined with prednisolone on alternate days. This recapitulated the strategy that we'd previously used with thalidomide on alternate day prednisolone, because we were quite comfortable that the alternate day prednisolone was well tolerated. The rationale for combining the 2 drugs was the well-known synergy between IMiDs and prednisolone. Patients also received prophylaxis against venous thromboembolism and against atypical infections. And the idea was to treat patients continuously until disease progression. In terms of tolerability, the combination really didn't hold any surprises for us, because we were quite familiar with using lenalidomide in combination with the corticosteroids. Because of the continuous nature of the drug, we did have to dose reduce in a subset of patients because of accumulative myelosuppression. And we did have some atypical infectious problems with a couple of patients developing pneumonitis. But again, this wasn't really surprising in a post-transplant myeloma population. So overall, the combination was very well tolerated, and over 50% of the patients still remain on therapy and are in ongoing follow-up. There are a number of very interesting observations that we've made so far from this work. I think first and foremost, it was very evident that people can get ongoing responses after an autograft when they put on this combination. And probably the most striking aspect of this was that in some patients, the attainment of their maximum response took up to 14 months post-transplant, suggesting that some of these patients have got very slow kinetics of response. Therefore, it's worth persevering with these sorts of strategies post-transplant. We also noticed, looking at the karyotypic data, that there was a fairly striking lack of efficacy in patients harboring 1q amplification, and that they really didn't appear to benefit greatly from the combination. But clearly this needs to be validated, I think, in larger patient populations before we draw any conclusion. Furthermore, at present, we've got the results of the multi-parameter flow cytometry and the free light data on those patients in serological complete remission. And overall, there's a reasonably good level of concordance between the two methods of looking at minimal residual disease. However, there are examples of patients who are negative on flow but still positive with light chains, and vice versa. And the interpretation of this will obviously require further follow-up. It's going to be interesting also to compare these data to the next generation sequencing data, which we're hoping to present at next year's International Myeloma Workshop. Overall, the study, I think, has been very valuable. The ability to compare multiple methods of MRD analysis within the same subset of patients, I think, is going to be very fruitful in terms of going forward, particularly what we may use in our day-to-day practice. Furthermore, the expectation that we'll get some interesting proteomic data based on the recent discovery of how lenalidomide works is going to value add to the study.